I'm Bree Luck, and you are listening to the Pause to Go podcast, where we explore the process of turning life's transitions into stellar transformations. You can expect interviews with experts, straight talk with remarkable humans, and conversations about making the most of every phase of life. Because when we approach life's stickiest spots with curiosity, support, and a little bit of inspiration, anything is possible. So whether you're on your way to work or settling in with your favorite beverage, together we can pause to go. As a solopreneur, I really like the flexibility to work from pretty much anywhere, so I'm happy to head down to Code-Based Co-working, where I can enjoy the company of others while I tackle my to-do list. Also, they have a state-of-the-art, consumer-friendly podcasting studio that is frankly my home away from home. So head over to Code-Based Co-working, check it out, and when you do, tell them that Bree sent you. For the last 2 weeks, you all have been sending in great questions about menopause, and I really want to thank you for that. But one of the questions that I got many times went something like this.
Hi, Bree. I was wondering why it is so hard to find a doctor that knows anything about women's issues or chronic illnesses that affect women like autoimmune disease. Every time I seem to have a smart question with a lot of research behind it, I get shut down, like I don't know what I'm talking about.
Hi, Bree. Love the podcast. My question is, why is the healthcare system so bad for women? Please tell me.
Hey, Bree, I've got one for you. Why is it so hard for women to get comprehensive medical care in this country?
I'm calling in to ask why the medical industry totally sucks for women. It seems nearly impossible to find a doctor that doesn't dismiss my symptoms or dwell on BMI. It's humiliating, and I often feel like a checklist rather than a person. And after talking to lots of friends over many years, I know I'm not alone in this. I'm wondering if this will ever change or why this even happens. Let me know your thoughts.
Getting adequate health care has been a common theme throughout this whole season of Pause to Go. We've talked about it in episode 1 with Dr. Teresa Diaz, in episode 3 with Dominique Cucuzza. Both gave their perspectives on why and how the medical industry shortchanges people who have had ovaries. And I'm going to have to plug Heather Corinna one more time. They were the guests in episode 6. In their book, What Fresh Hell Is This?, they wrote a whole medical history lesson that outlines in frightening and yet still entertaining detail the history of how medical providers have, shall we say, really screwed people with ovaries. And in that episode, Heather also gave some great strategies for dealing with this. Like, you can request not to get weighed at your doctor's office. And over in the Pause to Go discussion group on Facebook, I'll share some selections from a few really helpful books that might shed a little more light on this. But I really started thinking, who do I know who can give us not only a look at why the medical industry came to be what it is now historically, but who also forecast trends in the health system? Because I don't know about you, but I need to be looking forward at this point. So I reached out to my friend Jeff Goldsmith to see if he might be able to shed a little light on the situation. Jeff is the president of Health Futures Incorporated. He tracks and forecasts changes in the $4 trillion U.S. health system, and few have been at it as long as Jeff Goldsmith. For over 40 years, Jeff has analyzed changes in healthcare technology, financing, policy, and care organization. He's written for the Harvard Business Review and has been a source for articles on medical technology and health services for the Wall Street Journal, the New York Times, Business Week, Time Magazine. The list goes on and on and on. I really appreciated his insights and his wealth of knowledge, and I think you will too. I'm also sharing a PDF of 5 tips for talking to your doctor about perimenopause and menopause, based on this conversation and other conversations throughout the Pause to Go season. I'll share it over in the Facebook group, and I'll also share it in the show notes. And it's 5 tips about menopause, but really it could be used for any medical situation. And here's my conversation with Jeff Goldsmith.
So we ought to talk about women in medicine, right?
We do. So, as you know, I've been doing this podcast, and the first season was all about menopause and perimenopause. And recently I asked listeners to send me any questions that they had that I could try to get I'm not the expert, so I try to get someone who might be able to speak to it or address it in some way. And the question, by and large, that I've gotten it from multiple people. And it's probably the only question that isn't deeply personal, like, I'm having these symptoms, right? But the question that I get from multiple listeners is, why is healthcare for women so bad in this country? So I wanted to ask you this because I feel like you have a different viewpoint on the medical system than certainly I have. And also because you're looking ahead at the future. So on one side, I'd really love to hear your thoughts on why it's so problematic. I'm going to say problematic for women in this country. And then question number 2 is there hope? And what can we do?
Well, I don't know. I mean, there's a lot of running room there. A little bit of personal background. Believe it or not, I started working in the healthcare system almost 47 years ago. I was fleeing, working in the governor's office in Illinois, and landed in the dean's office at the Pritzker School of Medicine at the University of Chicago on November 1, 1975, as an assistant to a transformative new medical dean that had come there from Duke named Dan Tossison. And so I spent almost 8 years in a medical school environment, and then moved out into general consulting, where I worked in the health system as a whole, pretty much across the system, not just hospitals, medical schools, but large medical corporations, physicians organizations, pharmaceutical companies, biotech firms. I pretty much worked across the whole system. So, I think I've got a historical view based on that almost 47 years of watching this thing, but also more than just one sector of it. It's also worth noting that my mom worked in the medical care system. When she was pregnant with me, she was a lab assistant and doctoral student at Stanford University in their biochemistry department, was then called organic chemistry. And believe it or not, Bree, she was working on the team that was working on synthesizing estrogen.
Wow.
Yeah. Her team ended up founding a company called Syntex that made the first birth control pill. So, we actually go back a whole lot further than 47 years. To answer your question, when I entered the medical education system, there were a handful of women faculty members in our place. No chairs, no deans. We had only one woman senior faculty member in our place. And I can't remember, the graduating class or medical school, but it was well less than, it was a handful of women in our medical school at the time. So, I don't think medicine is all that different from the other professions. I think if you looked at the law schools, you would have found roughly the same proportions, almost no senior faculty. And, of course, women's health was, principally confined on the clinical side to OB-GYN, and on the research side to endocrinology, where you were looking at the role of the endocrine system. That was it. And so, from that standpoint, if you roll forward to 2007, by that point, you were beginning to get a significant number of women faculty in medical schools, and about a quarter of the practitioners in the country, this is 15 years ago, were women. Today, roughly half of the medical students are, and so each graduating class is replacing a cohort of docs that were 2/3, 3/4 men. Now, I don't believe that means you can't do good science related to the issues that affect women's health if you were a man. But even within that, we're now approaching a little more than a third of the docs in the country being women, practicing docs being women, they tend to pile up in a few places. They pile up in obstetrics and gynecology and pediatrics. Those are the two big ones. And, haven't distributed themselves in a random way in the total, either the science or the clinical enterprise. You look at the number of women that are medical school deans, there's a handful of them. It's worth noting that one of them is here at the University of Virginia, Melina Kibbe, who was appointed a few months ago, an absolutely brilliant appointment. And an even rarer duck, before being dean, she was a chairman of surgery at the University of North Carolina. You just flat out don't see that. So even here in 2022, though women are 80% of the healthcare workforce, their ascension to positions of power has been glacial. So I think that's a piece of it. I don't think it's the only piece that's relevant here. I also think that, like any other complex health problem, women's health problems cut across these silos that are rigid in medicine. And I think, I haven't listened to all of your podcasts. I've listened to a few of them, but the idea that there are elements in women's health that are endocrine related, there are elements that are mental health related, there are elements that are inherent in aging, which is different in men than in women. Those problems cut across so many disciplines that someone that wants to take a holistic view of the problem, which is the way patients approach it, they've really got the entire structure of medicine stacked against them. And that's not the paternalism that I was talking about earlier, but the way in which science and medical care is organized. It's organized into silos. Those silos are represented in clinical departments, but they're also in the discipline represented in communities of people that don't talk to the other communities. So if you're a practitioner out in the world and you're trying to solve a complex problem that affects the well-being of a patient, you've either got to become an expert in all of those things that are outside your silo, or you've got to have really great consultative relationships, have the time to read, and equally important, gossip widely with colleagues that are working on that same thing. So I think it isn't just a question of the numbers or the sort of patriarchal history, but also the way in which medicine itself is fragmented. And, you look at diseases that disproportionately affect women. Lupus is a great one. Another one would be chronic fatigue syndrome. These diseases took years before anyone really took them seriously. And I don't think that was because women, were the victims disproportionately, but because they cut across multiple disciplines. We're now discovering that they had viral origins, and that those viruses affected people's immune systems in ways that fundamentally destabilized them, like COVID is doing. Our medical care system does a very bad job of crossing those disciplinary boundaries and getting to solutions. And it does an even worse job of communicating that information to the millions and millions of people that need help. So that's a really long-winded, circuitous explanation of why I think this is so hard. And I don't know if it's blindingly obvious to, or not, but it's certainly what it looks like to me.
It makes sense. I love that you mentioned gossip as being something that we need. By gossip, I think it's just sitting around talking about stuff, right? It's really having frank discussions that are off the record, that are not, they're not being tracked. You're not going to be sued for your coffee shop chat. And it's been interesting doing this podcast because I've been able to get some functional medicine doctors on, naturopath on, alternative healers on, coaches, but no one who is working in the Western medical field, no MDs
Right.
who are not practicing alternative approaches have been willing to come on. And I feel like it's too scary to say what you really need to say in this litigious culture.
Or maybe people are just excessively respectful of the boundaries of their knowledge and don't want to be speculating about stuff they don't feel like they really understand.
Sure.
I mean, I've worked in and around both scientists and clinicians for, my entire career. And there is a reticence, and I don't think it's a conspiracy at all. I think it's just people respecting the boundaries of what they know and not wanting to speculate.
Yeah. I don't feel like it's a conspiracy. It's just, Yeah, that there's just a firm boundary there.
Just to back off and throw one additional angle at this, our medical care system is absolutely enormous. It's 2.5 times the size of Russia economically. 17 million people work in it. The vast majority of whom are women. So, I mean, I think the other element of this that is complicating is just the scale of the enterprise. And to add complexity to it, it's the most complex thing we do in our economy by an order of magnitude. And I'm not just talking about, serving 330 million people, but also the nature of the problems that medicine is attempting to solve. They're bewilderingly complex. And, you really have to be a complexity junkie. Full disclosure, I'm one of them. You really have to be a complexity junkie to want to dive into all those little silos and root around and kind of understand what's going on in them. I don't have a real job. I've been a free agent for 40 plus years. My main focus is where is this gigantic economic activity and cultural and scientific activity going? And so, what I do instead of working is I read and gossip on the phone with my friends about what I read and what I learn. So building that gossip network, back to what we were talking about a minute ago, a lot of folks don't have time to do that. And so their gossip network doesn't reach out beyond their discipline. It doesn't reach out beyond, the small subset of people that are sort of doing what they're doing. You really have to be into pain to want to reach out beyond those things. And of course, the way you get promoted in medicine is becoming the world's expert on the neurophysiology of the left big toe. And that's how you get promoted. It's how you get your grants funded. It's how you achieve professional eminence. So it's bewilderingly fragmented in addition to being bewilderingly complex. So I just wanted to add that dimension to it. And I'm not excusing this system's failure to answer the fundamental questions that you've been asking. But I think there are some reasons why those questions haven't gotten answered.
So it sounds like this complex system is also rewarding further fragmentation by rewarding specialization.
Well, here's a personal example. I have, like a lot of older people, I have neuropathy in my extremities, my feet and hands. And there were about 10 years ago when it was diagnosed, I was told that it would progress rapidly and that I'd be in a wheelchair. And I didn't like that. And I actually began looking at the literature on, what explains neuropathy, what is it, how does it work, all the rest of it. And I found a story that really troubled me. I was working at the time as an advisor to a president of a university that had a troubled medical school. The dean of that medical school was an expert on neuropathy. And he, in his pre-tenure career, he'd gotten the physiology of it down, and he'd actually found a really promising drug that could alleviate the problem that he identified that might conceivably have caused my kind of neuropathy. It was good enough research to get him promoted, and he got tenure. And the moment he did, he just dropped it. No one picked it up. And he went on to become, a medical school dean and then the head of the vice chancellor of a large health sciences center. So, the reward structure in medicine doesn't promote continuity. It's not like there was somebody who picked up his work and said, you know what, this drug didn't work, but maybe if we tweaked it a couple of molecules, we'd have a cure. There's no reward for that. So I think that's another piece of the culture that's really troubling, is that even with a condition that afflicts tens of millions of people, you don't get the continuity of effort needed to really press all the way out to a solution. And, you sort of need a societal crisis like the one we're having with COVID to force enough people to continue focusing until they found the remedies, until they found the vaccines, until they found the antivirals. That is an extremely unusual circumstance in most medical problems that don't rise to the level of a societal crisis as COVID has.
Well, it does make me think, is there anything that we can do as medical consumers? What can we do?
Well, look, I'm not advocating this as a solution, but there are dozens of different cancers. One would argue hundreds or thousands of cancers. I have friends that argue that each person's cancer is a unique disease. But there's a tremendous struggle for resources inside the cancer community. And women organized breast cancer initiatives that were so powerful and pervasive that they ended up grabbing what many people felt was a disproportionate share of money devoted to solving the problem. And we got progress on breast cancer that maybe you didn't see for, prostate cancer, cancer of the liver, or whatever it was, because there was a coherent, organized political campaign by people that had the illness and their families and their loved ones that ended up forcing Congress to appropriate money to the relevant institutes and NIH to get the thing moved along. So, I mean, it is certainly the case that focused political organizing can direct the flow of resources to solving problems. But again, if it's not a specific disease, and I realize breast cancer has, there's a bunch of different manifestations of breast cancer, some of which people don't think should be named cancer at all because they're not, they're extremely slow growing. But, when you're talking about, you talked about menopause and perimenopause, how do you focus scientific energy on understanding this phenomenon, which is, it affects half the population and in profound ways that affect their mental and emotional health as well as their physical health. And yet it isn't perceived as a crisis. It's not only not COVID, it's not breast cancer. So how do you generate a sense of urgency around unraveling some of those cross-cutting factors that we were talking about earlier to get the resources devoted, to get the scientists working, to get answers, valid scientific answers? That's a problem.
Yeah.
And a political solution is not necessarily the best solution.
And I mean, menopause is not a disease, right? It's not a disease at all.
No.
It's life. Yeah. Well, yeah, it is. And even hearing that there's a movement toward having more women in higher level positions, slow going though it may be, gives me hope. I'm an optimist, right? I'm a relentless optimist.
I'm a realist. I'm a realist.
I know you are.
And realism and optimism kind of join here. I think it's going to matter tremendously that we have women medical school deans and women directors of institutes of health and women advocates in the Senate that are no nonsense, powerful, get it done kind of people. There's kind of a critical mass phenomenon here. So I don't think the optimism isn't grounded in what we can easily see going on that is going to produce tangible results. It's just going to take forever. And that's one of the problems with my discipline of, looking into the future is, you can see stuff that you're pretty darn sure is going to happen. But the hard part is when, right?
Yeah.
That's the hard part. That's where my colleagues in the Silicon Valley and a lot of other places screw up, is that they think stuff's going to happen the day after tomorrow, and it almost never does.
Yeah. So given that, and I know that you are not offering medical advice in any way, but do you have any advice for women who are looking for medical care in this time, for women who are going through perimenopause and menopause in seeking help?
Boy. Well, to not be satisfied with not getting answers is one thing. You need to be relentless, and you need to ask the people that are caring for you at present to move a little bit outside their comfort zone, to take advantage of their networks to get you to people that can answer their problems, who may or may not be women. Mm-hmm. So I think that's a generic piece of advice for anybody that is dealing with the medical care system is don't be intimidated by it. Don't take, we don't know for an answer. Take it to the next level. Give me stuff to read. Give me conferences whose podcasts I can download. Let me attend meetings virtually, because they're all virtual these days, that might help me be smarter about what's going on with me, that will help me answer some of these questions, perhaps myself. Don't hesitate to leave providers that don't want to do that. If people don't have time to talk to you, you don't have time to be their patient. And I realize, having said that, I've been on a tear about how much professional time we are wasting of our clinicians' time by all of the typing that they have to do, all the documenting that they have to do, that, they spend half their time typing. That's time away from answering our questions. So, I'm kind of a terrifying patient. I'm sitting in the emergency room with a problem and someone starts an IV. And I'm like, why are you doing that? And not just because it's possible that they're going to waste money that, either I have to pay or that the, system has to pay, but because I kind of want to know what they're doing. I think people are excessively deferential. And I realize women are less deferential than men in some ways, particularly baby boom women. And I wrote about this in some of my early writings. Baby boom women revolutionized the whole business of being a patient. You go back to Our Bodies, Ourselves, which I think was a seminal document in women's health, maybe the wrong metaphor, but, there was a take no prisoners, get your needs met, define your problems in your own way attitude that was embodied in that, 50-year-old, almost 50-year-old document. It was brilliant. And a lot of it, what Our Bodies, Ourselves was trying to do, was produced by a feminist women's health collective in Boston, was to get people to not defer to the medical care system, to say to them, those folks, mostly men at the time, work for you. And if they haven't met your needs, don't let go of them. I mean, I just thought, I loved it. And it wasn't written for me, but I have that very same attitude. I can't tell you how many, wealthy, powerful people get into the medical care system and kind of go, oh, okay. Well, no, it's not okay. If your needs aren't getting met, you need to make noise, and you need to, and you need to be a bit of a pain in the butt. And I don't mean in an abusive way. That's something that's going on now, which is really scary. People are losing it in their interactions with doctors and nurses. That's not what I'm talking about at all. I think in a civil, thoughtful, responsible way, you don't let them walk away. You don't abuse them, but you don't let them blow you off.
I think it's great advice.
You can be polite and not be deferential.
Sure.
And I don't think there's any penalty for asking the person to take an extra 2 minutes to actually explain something to you and to give you the citations and to let you do the reading. And, part of my little challenge in the 80s and 90s was trying to understand more of the science. And, even if you can't read an article in Nature or Cell or Science, you probably can read an article in Scientific American or in lay publications like The Economist, which does spectacular medical reporting and doesn't talk about it. There are places to go where you don't have to understand what a glial cell is or, how RNA works to try and understand the underlying things that are happening to you. So I think that there is an intelligent layperson can get a long way towards understanding the science by reading some of those intermediate publications that have as their purpose trying to demystify and translate into English complex scientific concepts. Scientific American is fabulous at this. And most of the people that write for it aren't the scientists doing the work. They're science-curious journalists, people a little, in a way, like yourself, that have gotten far enough along in an issue to be able to say, okay, well, geez, this is really important. Here's what's going on. There's a lot of that information out there.
Yeah, I think that's great. And I think what I'm going to do after this podcast is draw up 5 ways to be polite without being differential to get the medical care that you need based on this conversation. I'm going to share it in the show notes and create a PDF from that. So, because I just think it's helpful just to remember when you go into the doctor's office, these are the things, before you go into the doctor's office, to be thinking about how to get the care that you need and to be curious about the information that you're receiving from your doctor and to demand curiosity of your medical provider as well.
I hope you'll underscore the polite part, because I think that one of the casualties of COVID has been a real rising hostility to people that are just flat out overmatched and exhausted. And I think we have to acknowledge the fact that they're really struggling right now. So I think, the idea of acknowledging that struggle is an important part of the foundation of this conversation.
We are all human. And if someone is attacking us, no matter what, we go into defensive mode. Even if we don't attack, we go into defensive mode. We're all trying to work together here. I know for certain that my medical care providers, who are excellent, only have my best interest in mind when they're giving me the medical advice that they offer, even if it's limited. And it is. So.
Well, it's interesting. I had a lot of medical care issues in a very intense 2.5-year period of time. And believe it or not, I mean, I've got a lot of choices, and a lot of, my gossip network's really useful for times like that. I ended up seeking out not only younger people, but women clinicians to take care of me. I had 5 major surgeries in 29 months, 4 of which were performed by women. And in my experience, for the most part, they're better listeners. Maybe that's from a lifetime of enduring mansplaining. They don't want to be like that, but they really want to understand maybe a little better than their male colleagues where you're coming from.
Yeah, one of my recent guests said that she's seeking out women from medical care for that reason.
Well, it's the women that I met in the process of doing this paid a pretty steep price during their professional upbringing just for being women. And I think it was sort of a challenge to not push back and to become arrogant and defensive, and to maybe remember what it felt like to not be listened to. And I have a lot of respect for people that have gotten that far in their own self-awareness. I'm tremendously optimistic about where our medical care system is headed, and I may be one of the only people in my generation that feels that way. I mean, the 5 surgeries that I mentioned to you in 29 months, only 3 of the people that touched me were over the age of 40. And it was stirring. That's a funny word to use. It was stirring to see the teamwork, and that's obviously pre-COVID, just pre-COVID, the teamwork and camaraderie and positive energy and spirit that those young people brought to dealing with me. I felt safe in their hands. And I felt like some of the fear that I was, trying to deal with, they understood it and they helped me cope with it.
One last question, and I don't know how much you can speak to it, is insurance. And I mean, because I know that for many of us, the kind of care that we want is not covered by insurance or is not adequately covered by insurance. And do you have any thoughts on the economic engine of the insurance industry as it pertains to women?
Honestly, no. I mean, I write about our health care financing system. I've lived with it and worked with it for almost 50 years. We've still got the better part of 10% of the population that have no health coverage at all. And we've got a significant number of people that nominally are insured, but who have policies with $5,000 to $7,000 deductibles who don't have the $5,000 to $7,000. And we've kind of looked the other way and pretended that it was okay. But what that huge front-end financial burden really is a 12-foot barbed wire fence between them and the care that they need, which is flat out not okay, and where the data on the human cost of people delaying care they need has not been tallied. Now, this is an area of real concern. Forget about the question of whether things like what used to be called alternative, which are now called complementary medicine, things are covered or not. It puts the patient in a completely untenable position of having to make value-based choices with no data, with no real recourse about whether it's worth me writing a check to do X that isn't covered by my insurance, or that is, the front end of which isn't covered by insurance. Now, we had this obsession in the 70s and 80s with the idea that if care was free, it would be freely used and there'd be a lot of waste. And people were trying to figure out a way to allocate risk to patients in a way that routine things that maybe weren't as serious were the patient's responsibility, but the really serious stuff was completely covered. And they never got even close to doing that correctly. That issue of how you allocate the risk appropriately just got punted. And I'm an avid consumer of complementary medicine. I've sampled every one of the possible things you can do, and I'm a believer, particularly in acupuncture. You want to have some fun. Ask a neurologist what it does and how it works. They still can't tell you in 2022. When Richard Nixon went to China in 1973 or whenever it was, one of the things they did was showed him a patient undergoing open capsule brain surgery where the only anesthesia was a few little needles in the person's ear. And he was like, what? What's going on here? Well, you'd think, in the ensuing 50 years, people would be curious enough about stuff like that to be able to answer the question. They still don't know what it does. There's this system of meridians. Okay, well, what are those? Can you take a picture of them? Do you know how they work? I mean, no one knows. So that bothers me.
I am a believer in acupuncture too. I don't know if you know this, I had chronic Lyme for several years and tried just about every modality of treatment and was really debilitated. I mean, couldn't hold a pencil. And finally, as a last resort before being put on an IV antibiotic for, 6 weeks or something, I went to an acupuncturist, and this is after 14 months of really debilitating illness. And within 2 weeks, I was 80% better. Within a month, I was 95% better. It was amazing. And I was not a believer.
Perfect.
Yeah.
No.
Yeah.
Well, it's compelling enough. I mean, I have a spectacular acupuncturist here in town, and my daughter found her, and my daughter worked in China before going on to Hopkins and getting a master's in public health. And she was intrigued enough by traditional Chinese medicine to want to go and study it in China. But when she told me about this person, she said, you need to go to her and tell her to treat you as if you were Chinese. And what that means is you put the needles in 1/4 of an inch and then attach electrodes to them. So, I mean, it's even the acupuncture, there are gradations of intensity.
Sure. Well, thank you so much for sharing your expertise and your vision for the future and for some great strategies for getting the care that we need as much as we can.
Well, I guess as a futurist, it's kind of arrogant to be optimistic when you're 73 years old, because I'm not going to be around to be held accountable if I'm wrong. But I think our medical care system is slowly moving in the right direction on a lot of the issues that you've been exploring. And I just wish the progress were more rapid.
Well, we just need to keep gossiping. Just keep the gossip going.
There you go.
Here are my key takeaways from this conversation with Jeff Goldsmith. Number 1, until very recently, women have not been in key positions as medical practitioners, researchers, scientists, funders, and in academic leadership. So the male bias or limited viewpoint was a factor in missing so much about women's health. But that's beginning to shift now that women are stepping into key leadership positions. And right now, women comprise roughly half of all medical students. Number 2, another thing to consider is that our medical system is heavily siloed. So doctors and researchers aren't really equipped or rewarded for taking on complex problems that cross disciplines. And many of women's health issues, like menopause and perimenopause, are complex and affect multiple bodily systems. Number 3, focused political organizing can direct a flow of resources to solving problems. Number 4, and lastly, and I think this has been a takeaway for at least 8 of the last 12 episodes, You don't have to defer to your doctor's opinion. Ask them questions. And if your doctor doesn't have time to talk to you, then you don't have time to be their patient. I'm posting a link to a PDF on 5 tips for talking to your medical provider about perimenopause and menopause in the Pause to Go Facebook group and in the show notes for this episode. Thank you so much for listening to the Pause to Go podcast. If you got something out of this episode, let us know. Share it with a friend, join our Facebook group, and subscribe, rate, and review on Apple Podcasts if you loved it. If not, no worries. We want you to tell it like it is, and we'd love to have your input. If you want to know more about what I'm up to, you can follow me on Instagram at TheLovelyUnbecoming or at my website, thelovelyunbecoming.com. Stay curious, y'all.